I know I'm scheduled to do a talk on innovation and talk to you about our new company called EnterTroy Bio, but because, good morning, Randy.
Hey boss, how you doing?
Good, how are you? Because we didn't finish all of our discussion on Monday or Tuesday, whenever Monday, on glioblastoma, I thought I'd finish with some innovation that we're doing around the malignant brain cancer we call glioblastoma. And so first, I'm going to take us back a little bit and talk about the history of medicine. I know my son Charlie's on the call, but I've always been a history buff for medicine. It's actually helped guide how I approach. So these are my ancestors: my father Billy, my grandfather Eddie, and my great grandfather John Bailey. We just got a new puppy we named after the Bailey family. So the history of medicine is an extremely important history, and if you're a doctor or nurse or PA, please make sure you understand the history of medicine. These are two early works by my great-grandfather, John Bailey. They were all ophthalmologists in Brooklyn and New York. But actually going back, not just on Thursdays, but every day into the works of others before you, I think allows you to innovate and make sure somebody has probably made the same mistake you have before you. And it's important to learn from those people. And then I found this picture of David Langer and Howard Rena. Howard Rena is vice chair of neurosurgery at NYU. This is when I was an intern at the University of Pennsylvania. And obviously you can see Langer was my chief resident. This is in, I think, 1997. Okay, so we talked a little bit last week, talk about glioblastoma. Glioblastoma is a malignant brain cancer, and you can see a malignant brain cancer here, this well-circumscribed 4-centimeter malignancy that's in the human brain. But there are cells that are 2 centimeters away and even further away. And in fact, Charlie Wilson in 1994 showed that there were cells of glioblastoma that could go even remotely across the corpus callosum to other sides of the brain. So as surgeons, we're very good at taking out these 4-centimeter masses, but we're not so good at hunting for cells that are left behind. And that's where our innovation and research is guiding us. Again, earlier works by others before me showed that I can safely disrupt the blood-brain barrier. We talked about this last lecture by using a drug here called mannitol. Mannitol allows our blood vessels to spread apart, and in so doing will rip these endothelial cells open and actually transiently allow the blood-brain barrier to open. This work was done, I didn't have to redo it. This was being done in humans in the late 70s. And so when we get new ideas, we want to take the experiences of others before us and use it in our grant applications and in our ideas for innovation. We talked about the blood-brain barrier. I just wanted to put this back up again to reiterate. It's a very complex structure and one that prevents things that are in your bloodstream from getting out into the brain. The blood-brain barrier is made up of endothelial cells here, tight junctions in between them, which are here in these black arrows. You can see red blood cells floating through the blood-brain barrier. You can also see part of your immune system here in eosinophils and monocytes flowing through the blood. These astrocytes form foot processes that also are part of the blood-brain barrier. This blue thing is called the blood basement membrane, also part of the blood-brain barrier. And we talked about the now evil pericyte, which is also part of your blood-brain barrier. So if you have a drug here, which is green, and you want to get it out into the brain, we better think of innovative ideas to open the blood-brain barrier and get drugs across. We have started a new company, which I'll introduce later, called EnterTroy Bio, which has the world's first blood-brain barrier permeability kit, which we hope will allow doctors to open the blood-brain barrier safely and deliver drugs. Other modalities exist for bypassing the blood-brain barrier. Our colleagues at Johns Hopkins, Henry Brem, and colleagues developed a polymer wafer that you can implant on the human brain when you open up the brain. And this, of course, bypasses the blood-brain barrier by allowing drugs to diffuse out of this polymer into the brain. We put microchips on the surface of the brain. We actually have a really interesting new microchip that we're using for spinal cord injury patients. So we can actually put a microchip on the human brain and hopefully get paralyzed patients to move their limbs again. And we do that with our colleagues in the Bioelectronic Medicine Center at the Feinstein Institute. Another modality of blood-brain barrier disruption is convection-enhanced or catheter-based deliveries. That's when you just put a catheter right into the brain tissue itself and squirt drug or materials in through the brain. So these are ways to get through the blood-brain barrier. So I'm going to talk to you about an innovative new trial that I started pre-COVID in about August of 2018, and it's involving using what we call surgical tissue flaps to bypass the blood-brain barrier in glioblastoma. So I'll tell you a story. I was doing a case in surgery. It was a big right frontal hematoma, and I was taking out the big blood clot, and I was under the scalp above the skull, and there's a big tissue plane we call the pericranium. And after I had taken out this blood clot, I realized that I had this big tissue called pericranium. And that pericranium is outside your blood-brain barrier. So I thought to myself, what if I take that flap and actually rotate it into the brain, and all of that blood supply would be outside of your brain and not have an intact blood-brain barrier. So I sent a medical student out of the room to look up the history of this idea. And sure enough, there was some history around it, but no one had ever done a human clinical trial of it. So with that, we opened a surgical tissue flap to bypass the blood-brain barrier in human glioblastoma, which is open and recruiting, and we've already treated 5 patients, the first on the planet to have this treatment. And I'm going to show you a couple of examples. So when we take out big brain tumors, this is actually a skull-based tumor behind the patient's left eye. So remember, my right is the patient's left, and here in white is a big skull-based tumor. When we take out that tumor, which is essentially here, we actually use these flaps that are under your scalp to actually repair that defect. And here you can see one of those flaps. This is called a temporoparietal fascial flap, or something called TPF. TPF is above the bone, okay, and it can be raised and elevated and actually stretched about 17 centimeters. And this is called the temporoparietal fascial flap. This is a slide I got from my colleague, Peter Constantino, who's a head and neck surgeon. And he's elevated this very large TPF flap. Look how cool that is. Now, all of this blood supply, all these vessels in this flap do not have the blood-brain barrier that we see in the human brain. That means there's no tight junctions between the endothelial cells in this flap. And that is the idea that I have. Could we pass this flap into my surgical cavity, and all of this blood supply now would not have a blood-brain barrier? So what does that mean? That means if I want to give a drug intravenously or orally, it should go through this flap and land in the human brain cavity and not have to deal with the blood-brain barrier. So here's another cartoon that one of our fellows, Nitesh Patel, drew for me. So here you have your temporoparietal fascial flap, or what we call pericranial flap. Here's the human brain. This blood supply should not have a blood-brain barrier. Here I've taken out a brain tumor in C as in Charlie. And now in D as in Danny, I'm tunneling that pericranial or temporoparietal fascial flap into the surgical cavity to bypass the blood-brain barrier. Here's another actual human example of it, okay? Here's the human hole that I made where I took out the brain tumor. Here's my autologous, which means from the patient, vascularized pedicle. This is the pericranial flap. And I'm now going to tunnel that and line the cavity with this pericranial flap. So there are 2 reasons why I think this is really cool. One is the blood supply does not have a blood-brain barrier. So I'm just going to show you this. These blood vessels are brain blood vessels. They have a blood-brain barrier. So they have tight junctions, they have astrocytic foot processes, they have basement membrane, and they have pericytes. The blood vessels in this extracranial supply should not have as tight blood vessels, tight junctions, should not have astrocytic foot process, should have less of a basement membrane, and should not have pericytes. So any drug that I give either orally, intravenously, should have a better time at getting out of this blood supply into what we call the microenvironment of this brain tumor. In addition, the second reason why I think this is cool is any antigens that the brain tumor is releasing, antigens are proteins that are recognized by your immune system, should be able to go back up the graft and be recognized by your lymphatic system, your lymphocytes, your lymph nodes, which have your T and B lymphocytes, and allow you to then have an immune response to those antigens. So again, we talked a little bit about tumor-associated antigens last week. I want this to help the immune system recognize these antigens. So that's sort of the basic idea. And I just want to let you know, just because you have a good idea doesn't mean it gets into practice. I think Steve Jobs said, innovation is not just a good idea, it's good execution. And then, of course, you have to be able to convince a human patient that they may be the first patient ever in the world to get your innovative new treatment. And that's what I had to do with this wonderful woman named Jennifer. Very intelligent woman with a very terrible tumor. And she came to me with, a year ago, had a normal MRI scan, and now has this very large temporal glioblastoma. So what I did was I took out this temporal glioblastoma, and I consented her, and she said, Dr. Boockvar, how many other patients have you treated with this new idea using a temporal parietal fascial flap? I said, Jennifer, you're going to be the first patient in the world to get this. And frankly, there are risks. There are risks of seizure, stroke, swelling. And she said, it's a great idea. She recognized and she reviewed some of the literature that I gave her on animal models of this, and she consented to be the world's first patient for this treatment. And we're incredibly grateful for patients like that who are courageous enough to really trust our judgment and our scientific rationale. Here's a video of her case. So I'm going to try to talk you through this slowly. Josh, let me know if you hear volume well.
All right.
In this short operative video, we demonstrate our technique.
I can hear it.
Placement of a pedicle temporal parietal fascial flap into the resection cavity of a right frontotemporal glioblastoma. As noted in the associated technical note, the patient is a 47-year-old right-handed female with a history of a newly diagnosed intracranial lesion. Prior to the craniotomy, the superficial temporal artery was mapped with Doppler ultrasound, and the standard temporal parietal fascial flap was harvested, pedicled at the STA.
You'll see a picture shortly. Here we go.
After performing a right frontotemporal craniotomy and temporal lobectomy, the tumor bulk was carefully resected using suction and bipolar cautery.
So I'm taking out the tumor here. Obviously, it's on high speed. Here you can see the brain tumor, okay? I'm using bipolar and suction, okay? This is basically part of the temporal lobe, and here is part of the frontal lobe. And I'm taking out the tumor. These are what we call cotton patties that help us with bleeding and show us margins. The tumor is often, these glioblastomas are often grayish and necrotic.
Once satisfactory tumor resection was complete, the TPFF was rotated into the field to assess.
So here, crap. Sorry. Let's try that
In
again.
this short
Okay, once I take out the tumor, you can see this is the temporal parietal
was
fascial
rotated
flap.
into the field to assess fit. Operator should assess fit of the flap to ensure there will be minimal tension. A preliminary fitting is made that potential tack-up points can be identified.
So there's my hole where the tumor was. I'm going to tack this and sew this to the human brain. And now this flap has no blood-brain barrier. So again, we want the idea being, can this provide
Note
us
the pulsating STA at the pedicle base on the top right of the screen.
STA superficial
It is
temporal
important to
artery?
periodically check for appropriate flow at this site. The TPFF is then carefully tacked up to the surrounding P arachnoid using 7/0 nylon suture and micro instruments. Once again, the operator should periodically check the STA to ensure flow. This can be performed with Doppler ultrasound easily intraoperatively.
So what's, obviously this is a safety trial. We got approval from the FDA to do 10 patients. We've done 5 already and have shown this to be safe. I can't say anything about efficacy yet because it's what we call a phase 1 trial. But this has never been done in humans before. And to do something, that's the first on the planet is gratifying in its own right. So don't be afraid of your ideas, no matter how crazy they
Door is
are.
closed in a standard fashion with an opening for the TPFF. Any of the commercially available glue substitutes may be used to better seal the dural defect. The bone flap is replaced and a small envelope box opening is kept to allow passage of the TPFF.
So there you can see the flap goes through the bone, and we sew the patient, put the bone back on, and then put the scalp back on as per usual. And just to go back to the history of medicine, people had thought about this before I did, and but they had never done it in humans. Mitch Berger, who then went on to become the chair of neurosurgery at University of San Francisco, California, San Francisco, did this in a preclinical rabbit model. So I called him and I said, "Why did you ever do this in humans?" And he said, "I never got the time or the resources to do it." So it's really important. When I wrote this grant to get it through the FDA, I had to quote this historical literature and show some of these pictures. The idea that came to me next after this temporoparietal fascial flap was to use something called omentum. Omentum is in our abdomen. It's a fatty tissue that basically protects the viscera or the organs in our belly. And so much like the temporoparietal fascial flap, I thought maybe omentum would be a nice way to bypass the blood-brain barrier also. First of all, it's softer, and it has a much bigger lymphatic source, which I'll talk to you about. Again, going through the literature before, decades before me, I found evidence that if you put omentum, which is fatty tissue from your belly, on the human brain, look what happens. Blood vessels will actually grow into the human brain, and those blood vessels, guess what, do not have a blood-brain barrier. So this would be a great idea, and actually we utilize this. David Langer does this for a host of diseases, including stroke from a disease called moyamoya, and we're actually doing this in clinical trials for Alzheimer's disease and other disease. It's never been done in human glioblastoma, but it will be hopefully in 2020 here at Lenox Hill Neurosurgery. Here's a picture of your omentum. For those of you who don't know what omentum is, it's actually a massive sheet of fat that's under your skin, in your belly, and it basically protects your viscera, the organs. Here you can see stomach and colon, and in that fat are beautiful examples of lymphatic tissue. Well, guess what? We can take that fat, actually pull it all the way under the skin, and actually plop it on the human brain, and that's a process we call a mental cranial transposition. And again, people who treat moyamoya disease, which is a disorder of basically occlusion of blood vessels, can get blood flow using these kind of flaps. No one had ever done this, though, for GBM. Our institution has a bunch of ENT and general surgeons that now know how to laparoscopically harvest this omentum. And so that means they can stick little holes in the belly and make those procedures safer. So we have this expertise now to grab this omentum from the belly minimally invasively, harvest it, plop it on the human brain, and bypass the blood-brain barrier. And this is an actual example of our team harvesting. That actually may be Randy D'Amico. Randy, is this you? No. Is an example here of a big piece of omentum that's been harvested from a human, and actually a portion of this will be tied into an artery in the neck, and then portions of this are put in the human brain, as is this example here. And this was actually all published. And again, cosmetically, this can look just fine because the skull and the scalp is repaired completely. And this now becomes a source of new blood vessels and lymphatic system to improve your immune response to your brain tumor. And this is what is in your omentum, something called Milky spots. Milky spots are immune, basically cells that are all over this fatty substance that is in your belly. So in these Milky spots, which are in your omentum, are B cells that make antibodies, T cells, which fight cancer, and a whole host of other dendritic cells, which are antigen-presenting cells that present antigens to your immune system. So although you got a lot of adipose tissue, which are fat, you have this beautiful source of Milky spots that are peppered all over this. So the idea now is to put this on the human brain and actually do see if it bypasses the blood-brain barrier. So we opened this just before COVID, and we have yet to have a patient enrolled because we were shut down because of COVID, but now we're up and running. So the name of this new protocol is what's called laparoscopically harvested omental-free tissue graft to bypass the blood-brain barrier in human recurrent glioblastoma. Okay, so this is just going to wrap up this first section, and I like this quote from Albert Camus of the plague. I have no idea what's awaiting me or what will happen when this all ends. For the moment I know this, there are sick people and they need curing. I think in today's day and age, this is even more relevant. So I'm going to shift gears. This is us doing clinical trials during COVID. We stopped all of our research in March, early March for glioblastoma, and we dropped everything and started doing clinical trials to test drugs for COVID. And we continued to do that using drugs from Regeneron, a drug called Sirilimab, which is an IL-6 receptor inhibitor, a drug from a host of other drugs, including convalescent plasma and Gilead Pharmaceuticals, and soon we'll be testing vaccines. But just to remind you that clinical trials save lives. Patients in clinical trials do better than patients off of clinical trials, and we try to get as many patients as we can into clinical trials. At Lenox Hill Neurosurgery, we run 38 human clinical trials, which is just terrific. So Josh, I'm going to switch gears. I wonder maybe if I should take a few questions.
Sure. I'll open up the chat for a second.
And then I'm going to do a little second talk.
You see the chat?
Yeah, it says no open questions. Dismissed. Hold on. I see no questions.
They're coming in the chat.
Oh, maybe because I'm sharing my screen.
Yeah, try stop sharing for a sec.
Okay. Oh, yeah.
Yeah.
Holy heck. All right. I'm going to take a couple questions. You spoke of Jennifer and her courage to become the first human patient to receive the flap. Is it difficult to have patients sign up for these experimental trials, especially when they have to disclose that not many people have had these treatments? It's very hard. And you just have to, a couple of things. You have to be very, honest about what you've done. You have to be honest about what the rationale is. And I can look at Jennifer in the eye and say, we've done this in animals. Every medication that you've taken has been trialed in animals and then in human clinical trials. So there always has to be a first patient for every clinical trial. But I said to Jennifer, I said, look, this should be safe. I think there are three risks, which we call the three S's, which is seizure, stroke, and swelling. And we've proven this in animals. We have the safe to proceed from the FDA and our local institutional review board. But, it's developing and make sure that you never have financial interest in any clinical trial. So I get paid zero whether she does the clinical trial or not. Because as soon as you bring in that bias, you can, be, falsely encouraging them so you make more money. So That's an important thing. So a good question, Sadie. Are there consequences that result from having blood vessels in the brain that do not have a blood-brain barrier? Absolutely. What if the tumor grows and likes the blood supply and grows along the flap? That's one of the risks, right? Maybe it's going to hijack the new blood supply, and this actually dovetails another question. So one of the risks that we watch for is to make sure that the tumor doesn't grow along the flap. Fortunately, the animal modeling before us did not suggest that it did. And in some of our early patients, there's no indication that it does, but that's something that would be a consequence of that. What's the infection rate? That's a good question. This technique can increase the infection rate. Why? Because we're taking extracranial tissue and tunneling into the human brain, and theoretically that can weaken the scalp and make it more prone to infection. So infection or CSF leak are a risk. Someone asked me what my quote was. The quote was Steve Jobs' quote. I'll put it in the, I'll put it to all. I think this is the correct quote. Someone has to verify this, Josh. It's innovation is not just a great idea, it's great execution. Steve Jobs. Josh, will you verify that? I think that's true. Okay. The recovery period, someone else is asking, is essentially the same. You know, whenever I'm talking to a patient in the office, I talk about the rule of threes or the rule of fours. What is that? It's either 3 or 4 hour surgery, 3 or 4 days in the hospital, and 3 or 4 weeks off from work. Remember, when you're talking to a doctor in the office, your brain is all over the place and you're not retaining that information. So I try to simplify things. And I usually say the rule of 3 or the rule of fours. I don't like to operate for a long period of time. I find that it's not safe. We know that surgeries longer than 8 hours have higher complication rates. And so we tend to not hustle, but don't dilly-dally. You're in, you're out, you get your job done. Okay, another question. Is the flap placed to help avoid recurrence or for initial treatment? For this trial, it's a very good question. It was for initial treatment. The omentum trial, the FAT trial, is for recurrence. So we have 2 different trials. The temporoparietal fascial flap is for newly diagnosed, and the omentum is for recurrence. Rachel, does this not harm the balance of immune cells or changes on the brain? Look, that's what we're here to find out. We're here to find out exactly what impact this will have on the immune system. Okay, and then I'll take 2 more questions and then go on to the next talk. Okay. Question is, there must be a reason for the blood-brain barrier. What happens without it when you use something like the flap? Well, we know the blood-brain barrier is very important for healthy individuals, right? We know that the blood-brain barrier is disrupted not in glioblastoma, but in, for example, multiple sclerosis, which you heard from Dr. Filippi. That's when there's inflammation in the brain and demyelination. So the blood-brain barrier is very important for us, and evolutionarily protected us from, getting, boa constrictor venom in our blood into the brain, for example. So, but you can bypass the blood-brain barrier when you have an alcoholic beverage, which I know none of you do. The feeling of intoxication is because alcohol bypasses the blood-brain barrier. Same thing with hallucinogenic drugs. So we have a host of modalities to bypass the blood-brain barrier. The question is, can we harness those techniques and improve the delivery of something like brain cancer? So with that, I think I'm going to shift gears and talk to you about how do we take ideas and get them into biotechnology. So I'm going to share my screen again, Josh, okay?
All right. Dr. Boockvar, people are asking about the merch.
The what?
The merch.
Oh, the merch. my wife Jody's working on it. We will have merch by August. The merch store will be up and running. Josh, just take an informal poll as to what people want. T-shirts, long sleeve shirts, hoodies, hat.
I'll put one in the Facebook group.
Again, all, and they'll be not pricey, but all purchases, money will go to research like this in the health system. Okay, so how do you take an idea? Do you see my screen?
Yep.
Okay. How do you take an idea and bring it to market? And how do you take a concept as a doctor or nurse or PA or anybody? We had a janitor in our health system who decided that the bottom part of the drapes that separated patients were the part that he was cleaning and kept getting very dirty. And he came up with the idea that there would be a removable lower portion of the drape that separated the patients, like a Velcro. And he patented that idea, and then now is the lead investor on a company that makes those drapes. So anybody at every level, if you have an idea, write it on a napkin and make someone document that you were the first with that idea, because it can come back and help you. So this is a true story. We were actually been studying blood-brain barrier disruption for years, and I'm going to talk to you a little bit about how this company was formed. This company, which I'm currently the founder and CEO of, but hopefully not for long, as I don't want to be CEO of this company. We hope to hire somebody new. But taking our expertise in intra-arterial drug delivery and blood-brain barrier disruption, we created a company that's going to help basically scale what we do at Lenox Hill Hospital and the Feinstein Institute, and make sure that anybody everywhere who wants to overcome the blood-brain barrier can do it safely. So I go to a camp up in upstate New York, just north of Lake George, called Baco and Chenoweth. And I was driving home from camp one year, and we drive through Lake George and Saratoga, and then Schenectady and Troy. And I was entering the city of Troy, and it came to me that, much like the Trojan horse were used by the Greeks, I think, to get into the city of Troy, we are trying to overcome the blood-brain barrier by sneaking through this very large gate, much like the Greeks were trying to do when they entered Troy. So I pulled over and I Googled the name EnterTroy, and fortunately there was no name EnterTroy Bio. So I went on GoDaddy.com and I bought the domain name, and then we started this company. So we started a company called EnterTroy Bio, and the mission of this company is to take what we're doing in humans and actually scale it, produce products that actually can help do this. And our job is to disrupt the treatment of brain cancer and other CNS diseases by making sure we can get access across the blood-brain barrier. So here's a little bit of the business overview. Again, we talked about this, but again, now I have to be able to talk like a business person and be able to tell an investor, okay, here's a company with a product and I need such and such investment. And this is part of that, what we call a pitch deck. We talked about the problem of overcoming the blood-brain barrier. Here again, you can see a nice picture of the blood-brain barrier. Here are your endothelial cells. Here are your gap junctions. Okay, here is your nemesis, the pericyte. Here's your astrocytic foot process. You have a basement membrane in here. And just to remember, 98% of potential drug treatments, even if they're considered really small, do not cross the blood-brain barrier. So 98% of our drugs, even the small molecules, never get here. So here you can see a drug, and it's never going to get out of the blood-brain barrier unless we can give it the opportunity to do so. So I think we showed some videos. I'm going to show another video. So I came up with this idea to make a blood-brain barrier permeability kit. And this is the kit that we hope to sell across the entire globe. And this is a blood-brain barrier permeability system. In it is a multi-port microcatheter that is proprietary, meaning that we have the intellectual property. Doctors Ortiz and Langer are the co-inventors who are helping me make this special microcatheter. We have a unique microinfusion pump here on the right, and actually my nurse practitioner, Cherise Fralin, who's a world expert in infusion, and Tamika Wong, who runs our clinical trial, are co-inventors of the pump. And working with our researchers at the Feinstein Institute, we found new drugs that open and close the blood-brain barrier. You know that I use mannitol in humans, but now we have other drugs, including a novel drug called MIF, which opens the blood-brain barrier. And we have ways to close the blood-brain barrier now with a drug called L-thyroxine. Just to let you know, though, these two drugs are not human-ready. Our company needs to do a lot of work to get this into the next, what we call phase of being in humans. So until that time, in this kit, we also provide mannitol. So this is a picture of the blood-brain barrier permeability kit. And again, we showed this video last time, but this is how the kit is going to be deployed. Dr. Ortiz here is putting a microcatheter into the patient.
This is the vertebral artery, and he's snaking this catheter up.
And the catheters go up into the human head. We give mannitol or MIF to break down the blood-brain barrier. How cool is that? I still find this so cool. And you can see the blood supply of these tumors is extensive. So you need experts like Ortiz and Langer to do this, okay? And then once that blood-brain barrier is open, we can spray whatever chemotherapy or drug treatment, viral vector or therapy. And our team has been leaders in this modality for about a decade. It's actually almost just over a decade ago, we were on the cover of New York Times Science Times. So we are positioned to be world leaders in this treatment. Here you can see Dr. Langer doing it. Now, why would a hospital want this? And this is where you have to convince your investors that you're going to make money as a company, right? So we hope that this kit, the blood-brain barrier permeability kit, will actually allow you to use much less of the drug than if you gave it orally or intravenously, because you have to give much higher doses orally and intravenously to bypass the blood-brain barrier. Here, with our catheter techniques, we should be able to use much less lower drug concentrations, so that's cheaper for the hospital. And all of the carriers, a carrier is like United or Aetna or Blue Cross, they are paying for these catheter-based delivery of drugs to the brain that you've seen. So we have a modality for the insurance companies to pay us. And I wrote a paper that basically shows that if you do a treatment for this in glioblastoma, you can save a hospital about $500,000 per patient per year. So not only are you going to make money as an investor, but you're going to save your hospitals money. And we went out and got patents for all of these, this intellectual property. That's a big to do to get a good patent portfolio. And so we became leaders in this endovascular delivery. We have patents on a host of drugs, including Avastin, cetuximab, Herceptin, carboplatin, and temozolomide. Obviously, we've been in human patients for many years, and our patent applications have all been filed and are related to the novel microcatheter, the new pump, and obviously some discovery work with new drugs to open and close the blood-brain barrier. Now, Northwell Health is incubating my company, meaning that they're providing me the resources and actually the financial support to make this company great, okay? And we have other companies that we're competing against, much like we talked about in that first slide. So we believe our company is the best because it's efficient. It doesn't require open brain surgery, just requires snaking a catheter all the way up into the human brain. Other companies that are trying to use these transport mechanisms, those drugs need to be given intravenously. We think they have higher side effects. The convection enhanced delivery companies where they stick a catheter in the brain, it requires brain surgery. Same with the device companies where you have to put a little wafer or whatnot on the human brain. So we don't need open brain surgery for our company, and we think that's an advantage. Look how big the market is for the blood-brain barrier. So this is when we talk about the market, let's say you want to sell, you know, I don't know, wrist bracelets or body tattoos. You got to figure out what the market is for your product. Yeah, I'm sure you guys all watch Shark Tank. So in watching, this is like brain Shark Tank. So I had to figure out what is the market for these products. And the global drug delivery blood-brain barrier market is just expanding rapidly because our population is aging, and all of these diseases are becoming more and more important in our aging population, including Alzheimer's disease, seizures, Parkinson's disease. We talked about MS. And brain cancer is actually a small slice of this, but it's a very, very fast-growing market. And we actually measure that in billions of dollars. So the market size for drugs that need to cross the blood-brain barrier is going in the next 5 years up to about 4.6 billion at about a 30% growth rate. So these are really important numbers because you want to be in a market that's growing, not shrinking. And fortunately or unfortunately for humanity, this market is growing. We talk about research and innovation. This is the keys to making, you know, anybody can be a surgeon, anyone can be a doc, anyone can be a nurse or a PA, anyone can be in healthcare administration, but coupling research and innovation with good execution puts you on top, period, end of story. We talk about an addressable market. Of that big market, what is going to be the addressable market of my product? What is the actual number of the United States patients that may benefit from my treatment? We know the incidence is the number of new cases per year in the United States. The prevalence is the number of total cases in the United States. And we can calculate these numbers. And so we can come up with an actual number of patients who may benefit from our treatment. And that we call the addressable market. How do you get your valuation? Well, if I have this number, 18,000 plus 100,000 plus 65,000 plus 500,000, and I want to sell each product for at least $50,000, and we assume that the cost of producing our kit is $10,000, that means per kit we make $40,000 per kit, and we treat somewhere between 10 and 20,000 patients per year. That gives our valuation of our company somewhere between $500 million and $1 billion. That's just, these are preliminary financial models. I don't do this, our finance people do it, but this is how you come up with some of these assumptions. And again, I think our management team is what makes people want to invest in us. And obviously myself and Dr. Langer, we have great scientific officers at Feinstein, and including our nurse practitioners. So you can see that it's MDs, PhDs, financial people, nurse practitioners, PAs, everybody's involved. I have slides and slides of our management team. But this is really such a fun part of what we do. And we have to raise money. Why? Because we've got to do the work to get this product. So our initial money we're trying to raise is $5 million. That may sound like a lot, but it's really not a lot. We hope that this first capital raise, which happens at the end of 2020, we need $1 million to make our microcatheter. We need $1 million to make the infusion pump. We need $2 million for the small biologics. And I need $1 million to hire a new CEO. So, and other people. So that's how we do things. Here's our timeline. We hope to raise this money over the next year or so, and then continue to raise more money. And that's what happens in the business of biotechnology. You're constantly raising money and actually diluting your own equity as you raise more and more money. But at the end of the day, you're not in it to make a buck. You're in it to cure human disease. And that's what our goal is. So at that point, when you made your kit, these are companies that may have an interest in actually buying your product or buying your company. And these are all companies that would have an interest in our devices. And that's called an exit strategy, when you kind of will offload your own company and have it purchased or licensed out to a larger company. And these are some larger companies that would have an interest in that product. So This is an investor deck. With an investor deck, you put in an appendix, again, showing that your leaders, how all the publications that we wrote, some of the preclinical modeling, which we talked about last week, how it is impacting human disease. And again, we talk about the blood-brain barrier, but this is sort of what we call an investor deck that we give to our investors. So with that, I will stop sharing again. And Josh, why don't you open up the chat again?
Yep, opened it up. Someone said, how the hell do you find time to operate, research, and run a business?
You know, I think that's a really important question. And by the way, I get home to my children and my wife also. So it's really important to learn how to balance your time and be efficient, and then delegate. You know, people like Randy D'Amico have joined us from Columbia, and you know, Randy is so talented. He can run this business on his own. You know, you get yourself in a environment where I don't know if David Langer's introduced the concept of flywheel yet to you guys, but everything you throw into the wheel just generates positive results. And we believe we're in this flywheel mentality. So, you know, I've always surrounded myself with good people. I've delegated work, but you want to make sure your ideas are, you know, being vetted by good people, and you pray that it all works out. But you got to work hard, and you got to be efficient. And you got to be efficient early in the morning. If you're a surgeon and you're operating after 3 p.m., you got to have a good reason why. Because once the sun sets, I don't like to be operating. That's just my opinion. Okay, so Randy, any comments while I read this blistering chat thread?
No, I think it's great. I agree with you. I think it's finding a good team. I think that's the main thing. And, you know, I mean, I know because I watch you do it, but you're running a clinic, you're running clinical trials, you're amazing with your patients, you're performing operations, I mean, multiple days a week. I mean, at least, you know, 4 surgeries a week at least, sometimes more. And on top of that, you know, launching a company, which before that gets going is a lot of work, you know? And so, and then raising, what do you have, 4 kids at least?
A new puppy.
And as a, you know, I have a 3.5-year-old and he keeps me busy. So I can't imagine having 4 of them. So yeah,
my kids are amazing.
Yeah, you know, someone drew it for me once a long time ago. They drew 3 circles overlapping, and it was family, career, and you know, personal. And they told me that the ideal situation is to find, you know, the perfect mix of all of those, to find a way to mix them all together. And I mean, I think you're an excellent example of that. And so,
well, thank you.
Yeah, you gotta deal with what you got and make it work.
This is what Langer gave me this. I don't know if you can see this. Can you read this, Randy?
I mean, exactly. That's the exact drawing.
So Langer gave me this like a long time ago, so I put it up on my bulletin board. No, you need to be able to, you need to prioritize stuff. But you know what? They're all overlapping, and so one thing leads into another, and
yeah.
Just get
I think the key here is taking a passion, right? Like you can learn how to do surgery, you can learn the technical aspects of it, and at some point, I wouldn't say you peak, but you become very comfortable with it. You know what the limitations are, but there's a disease process that we don't know how to fix, and finding ways to fix that, and then having the you know, the intuition to expand that to other disease processes too is huge, and it keeps you motivated. It keeps the inspiration in you to keep going and keep pursuing this stuff. That's the reason I think people should go into medicine and you know, care about the diseases themselves, and in addition to the individual patients.
Yeah, I think that's exactly right. In fact, but look, it's getting harder and harder with the bureaucracy and our other issues. But just stay laser focused. I think, you know, Randy, for example, is a junior faculty. Now, those early years are extremely important for fertilizing the ground that you're going to create for growth in your career. And, you know, people are going to tell you have to do more cases, you got to make more money for the department. Your only horse you should ride out of your residency is actually your research, and to get that focus on where are you going, what's your niche going to be? Where are you going to practice? Are you going to be surgical neuro-oncology? Are you going to be more Jason Ellis who's doing vascular disease? Or you can do research in, microRNA, whatever it is. So you just have to sort of stay true to your passion. Just remember, you're good at what you like and you like what you're good at. And that's should guide you even if you're in high school now. So you're good at what you like and you like what you're good at. And that should guide you. Don't start doing something because your parents tell you to do it or because your older brother was good at it. Stay focused, and I think that can help.
So one good question I'm looking at here, someone asked about insurance coverage for the treatment. Obviously I've done a lot of work with convection enhanced delivery, which we talked a little bit about last time. And you and I had this discussion about how difficult it would be to get that covered by an insurance, because that's an extra procedure. Obviously, in the clinical trial stage right now, but without any confirmed benefits, versus this, which is, it's an extra procedure, but it's a more cost-effective procedure in general, and you're delivering treatment that's approved. So can you speak to that a little bit?
Well, I think you're right. So what's beneficial about what Dr. Langer and Ortiz are doing for me for brain cancer is everything they do, they do routinely for other diseases, right? So they do endovascular treatment for stroke. They do endovascular treatment for coiling of aneurysms. They give endovascular treatment of verapamil for vasospasm. So fortunately for us, and it goes back to Randy, I'm not sure you were here, where we had a long history, talk about the fundamentals of the history of medicine, where intra-arterial drug delivery has been done for decades. And it continues to be done in human diseases. For example, if you want to give a drug to the liver for cancer, for example, the intra-arterial delivery of the hepatic arteries is commonplace. So fortunately, intra-arterial drug delivery is not necessarily experimental. Whereas convection enhanced delivery, where I'm making a hole in the skull and putting a device in, is experimental. There's no actual catheter. There are catheters that are being approved, but it's much more experimental than the endovascular utilization of intra-arterial techniques. And so actually we applied to CMS, which is a Center for Medicare and Medicaid Services, and they approved this treatment because of the previous human data and other technologies that are using intra-arterial drug delivery. But again, that could have gone either way. And then I would have had to start a biotech company that got the funding to pay for the surgeries and the catheters. So we're fortunate in that capacity that these procedures are covered, and frankly, rightfully so, by insurance providers.
Yeah. Another good question that I think dives more into the inspire component of what we're doing with this whole thing. But someone asked, how do you get these projects started? Do you dive into an idea that comes to you, or is it more of a process of deciding what ideas are worth pursuing and how you'll pursue them?
I'm just going to talk from experience. So my idea for intra-arterial drug delivery with blood-brain barrier disruption really came to me during a barbecue with Howard Rena, who I showed you that picture of, which is a Throwback Thursday picture. I was at a barbecue near our house with Howard, and this is when I was at Cornell, and he was called from the barbecue to do an endovascular clot retrieval. And he said, John, would you man the barbecue for me? We were having a resident barbecue. So I flipped burgers for him for like an hour and a half. And he came back. I said, Howard, what'd you do? He said, well, I got all the way into the anterior choroidal artery and I pulled out a clot. And I said, Howard, are you really that quick now in the microcatheterizations? And his quote was, I can get anywhere in the human brain. So actually that really piqued in me an interest to say, hey, wait, the technology of these endovascular guys are so much better than it was even a decade ago. And that's when I started looking into intra-arterial modalities for blood-brain barrier disruption. So some of it is serendipity. Some of it is don't be afraid to look in the history of, start researching some good ideas. Somebody probably has a similar idea to you, but it doesn't mean it's not worth pursuing. Other people thought about using omentum before I did, but they did it in rabbits and never really took it all the way to humans. And so, again, it's just making sure that you know what you're good at and follow that passion.
I think that's great. I think the main thing too is, it piques your interest. You start becoming interested in something, and then you can follow it. And the nice thing about, where you are career-wise, and even early on when you choose a residency, is that you are given the authority to make these decisions and pursue these things. And, you have an education. You're not limited in what you can do. You can actually follow kind of these ideas because you've learned how to research them and come up with supporting data and argue for them. And so I think it's really, that's a huge part of it too.
And look, I know there are a lot of students and on the call, even if you don't go to medical school. And I have an identical twin brother, and he came out of Penn Law School thinking he would be a lawyer, and he jumped around from company to company, getting a skill set at various companies, some of which went bankrupt during the .com bubble burst in 2000. So you take some risk in life, and his most recent company was the fastest growing unicorn in the history of the United States. So unicorn is $1 billion valuation company. So some of it is luck, some of it is just persistence. And like Randy said, I can't emphasize enough, regardless of your political inclinations, the book 0 to 1 by Peter Thiel, who started PayPal, is a great read. I think I have it here. It's called 0 to 1. How do you take a zero in your space and make it one? You're the first company in that space, and that's what PayPal was. And so the book 0 to 1 is a really great example of how you develop that N of 1 in a space. And we help to be the N of 1 in the blood-brain barrier permeability space. One of the first chapters that Peter Thiel talks about is getting those early hires, Randy. Those early recruits are fundamental to getting your business off the ground. So again, that's really extremely important.
Yeah, absolutely. This was great. I think you're the last one of the day. You can keep going, or we can end it.
No, I'm going to wrap it up so I can go do my pituitary case. And the only other piece of advice I'd give you is, and whether you're interested in having kids or a spouse, partner, make sure you make time for your family and your personal life, because if you're only working, you're not going to get enjoyment out of other things in life. And some of that, there's a lot of peer pressure, as you know, in medicine to stick around, do more work, do more cases, do more everything. And it's okay to say, you know what, I'm not sticking around. I'm going home early today. I'm going to, go for a bike ride or go for a swim or whatever it is. So make sure you balance your time and do it appropriately. All right.
Great words. Thanks, everyone. We'll see you tomorrow.
Bye, guys.
Thank you.
And you told them no buy the book today, right?
Yeah. There's no buy the book. We're going to go bi-weekly or even monthly for the summer months. So, but we are having buy the book next Thursday at 4:30.
Excellent.
Okay.
All right, guys. Enjoy your day.
Bye-bye.
Thank you, everybody.